Our next speaker, who is another person who has made significant contributions to the field of monoclonal gammopathies. And the next topic is monoclonal gammopathies diagnostic considerations, and the speaker is Dr. Rajkumar.
Hi, good morning. Welcome to Mayo Clinic. I'm going to be talking today about diagnostic considerations. As you know, the diagnostic criteria for MGUS, for smoldering myeloma, multiple myeloma has changed. So I'll walk you through some of the changes. I'll also cover a little bit about MGUS itself because I don't think anyone else is covering that during this course. So we'll go through that and then happy to answer any questions you have. I have no conflicts to disclose. As you know, until recently, MGUS, smoldering multiple myeloma, and multiple myeloma were defined like this. We basically looked for presence or absence of the CRAB features. In order to make a diagnosis of multiple myeloma, you needed to have CRAB features. If you didn't have CRAB features, you either had MGUS or smoldering multiple myeloma. And then we split MGUS and smoldering myeloma into two groups based on the percent of plasma cells and the level of the monoclonal protein, so that if you have no CRAB features and the plasma cells in the bone marrow are less than 10% clonal plasma cells, less than 3 grams M spike, that would be MGUS. More than 3 grams or 10% or more plasma cells would be smoldering. So this is how we split them. Part of the problem with this definition, which is basically based on clinical features like presence or absence of CRAB features, differentiates the two, is that until you get CRAB features, it was not possible to call somebody as multiple myeloma and start therapy. So even if you know somebody's going to have a problem soon, you couldn't actually start therapy. So for example, if you had a high level of light chains and you think the patient's at risk for renal failure, you would have to wait until renal failure occurred and the patient developed CAS nephropathy before you could start therapy, which puts us into what we call a catch-22. You don't want bone lesions, you don't want renal failure, but at the same time, you cannot start therapy until one of those two things happen. So this is very important because if we are going to delay progression of MGUS or smoldering myeloma to myeloma, we have to start thinking about the right time to intervene. Now, if you look at this curve, you can see that the progression rate of MGUS is only 1% per year, and it goes on indefinitely. If you look at this other curve, this is the progression of patients with smoldering multiple myeloma, and two things are striking.